All right, welcome everyone to the Society of Thoracic Surgeons, the General Thoracic Surgery Database monthly webinar. Today is Wednesday, May the 8th of 2024. I cannot believe we are already in May. Summer is just around the corner and I am counting down. All right, so for the agenda today, just a quick welcome and introduction per usual. Then I'll cover STS updates, and then we'll turn things over to Ruth for a quick education update. And then, as usual, we'll finish off with our Q&A. Please be sure to enter your questions via the Q&A function and not the chat. Also, if you'd like to just ask your question, we do have that raise hand function enabled, so just be sure to raise your hand and make sure that your microphone is enabled on your end. On the call with me today, just from the STS side of things, myself and Carol Crone, the STS National Database Director. We have Emily Conrad, and then from Core Group and STS Consultant, we have Katie's joining us from Core Group, and then Ruth is, as you all are very much aware, our GTSD consultant on board today. All right, STS updates. The May training manual will be posted either later this afternoon or no later than tomorrow. I am in the process of getting the bookmarks added to it right now. So once I'm done with that, I'll pass that over to marketing to our marketing team and get that posted. So again, that'll be available either later today or by tomorrow afternoon. Just depends on what the marketing team has going on this afternoon. Spring 24 harvest reports were released on Monday, April the 29th, and that official notification was sent out to everyone on Friday, April the 26th. If you have any questions regarding those reports, just please to continue to submit those questions via the STS help desk. And I should have included the email address there as well, but the email address is stsdb_helpdesk@sts.org. So again, any questions harvest report related, just please send those to the help desk and we'll get those answered for you. The fall 24 harvest is currently underway and it is scheduled to close on September the 6th. That fall 24 harvest will include surgery dates of July 1, 2021 through June 30th of 2024. And that opt-out date is scheduled for September the 10th. Also, the neoadjuvant therapy module resources are now available out on the STS website. Let me pull that over. And show it to you. So the neoadjuvant therapy module resources are now available. We have that supplemental training manual for the neoadjuvant therapy module. We also have a REDCap supplemental resource, which Carol is going to go over here shortly. She's going to review that for you. We've had some updates to the REDCap. Some functionality updates. So Carol's going to review that for us here in just a moment. And then also the data collection form is also posted out on the STS website. We have both the Word and PDF versions. So out on the website under the General Thoracic Surgery Database data collection resources, you'll see we have our version 521. And then now we have the neoadjuvant therapy module data collection resources. Just click here. And we have our training manual that used to be at the back of our GTSD training manual. We pulled that out now and have a separate training manual for the REDCap module. So the training manual for REDCap is now located here. Here's the link to the supplemental resource document that we're going to go over here in just a few moments. And links for the data collection forms if you'd like to download the data collection form. Again, we have the PDF and the Word versions available. Alrighty. So with that, I'm going to turn things over to Carol so she can go over the REDCap supplemental resource form. She can explain some of the new functionality that we have within the REDCap form. So Carol, it's all
Thanks,
yours.
Leanne. I'm here. Hi, everybody. Okay, I'm going to go ahead. Is it okay if I go ahead and share my screen?
Absolutely.
Okay.
I think I have to share.
All right. Let me know if you're able to see it. I think,
yes, ma'am.
All right, Zoom changed a couple things here, so. All right. So I'm at the screen where Leanne left us. This is the general thoracic surgery database. And then we have the, Leanne has built this nice drop down for the neoadjuvant therapy module data collection resources. Under this, as she said, there's the REDCap form supplemental resources and the training manual, which has been pulled out. Under the REDCap form supplemental resources, we have updated a few functions, some of the functionality within the REDCap platform to help with tracking at sites and reaccessing the forms and doing updates to be easier at the sites. So that functionality is available. Here's the link to the GTSD neoadjuvant therapy module. The same PDF is also posted on the ACSD side with screenshots specific to adult cardiac, and then here are the two links for the adult cardiac beta blocker project and the valves, implants and explants for valves that were not available at the start of 4.2. So a couple things to note here. This is the STS patient and STS record ID. We have been having quite a bit of issues with sites entering in the correct numbers here. This is both of these numbers. If you use vendor software, both of these numbers are provided by your vendor. They're not your medical record numbers or anything like that. This is an STS specific number that is calculated or provided to you but from your vendor software or within IQVIA. If you're a direct data entry within the IQVIA, it's always going to start with a V, and they're going to be two separate numbers. So patient ID identifies the patient. Record ID is specific to the patient. Patient IDs can have multiple record IDs. So it's kind of like a procedure ID. So if a patient has multiple procedures, they would have the same patient ID, and then they would have multiple record IDs, a different one for each procedure that's entered into the database. And I think we have some screenshots here. Going down a little bit further, I'll show you some more information on those V numbers or the STS STS record and patient IDs. So deletion, updating, and editing of REDCap forms. If the form is entered incorrectly or needs to be updated, the next 4 slides are going to help you with this. Again, this is all posted on the STS website under the neoadjuvant additional resources. We have functionality built in now that will give you a return code for the case once you enter it into REDCap, and we're going to do a simulation of that as soon as we get through these slides, so you can see what that return code looks like. So if you don't have the return code on the forms and you made an error, then you need to re-enter the form. The most recently submitted form will be used in analysis. And if you don't have the return code for the phone, but you need to update a record, a record deleted because the record should not have been entered, you'll need to reach out to the help desk. And here's the link here right within the form to reach out to the help desk to help delete that record. Submitting to a REDCap form. Once you submit the form, you get to the end of the survey, or you get most of the survey done, but you need to get out of the survey for some reason. It's now going to generate this return code, which is specific to the patient that you entered in. The code has to be saved at the time of submission by the site. STS does not have access to this code, so it would be your responsibility to write this code down. My suggestion is that if you are participating in this, in the neoadjuvant data collection, these patients are going to also be on your tracking log, if you're keeping an Excel spreadsheet or however you're tracking your patients for their 30-day follow-up status, post-discharge, or readmission status post-discharge. However you're tracking those patients, this is a place where that's the same place where you should write this code down so you have access to it. And I'll show you how this works once you get, oh, I'm sorry about that. Once you get the form saved, you can re-access the form by using this code, and we'll go through an example of how that works. And then you could download your survey responses here and save them right to your desktop if you wanted to keep them for internal tracking purposes. We'll look at all of that, see what all that looks like. How much time do I have, Leanne?
Oh, you're good.
Okay.
Yeah.
If you need to save your form and complete it later, there's this now going to be the save and return later button. And that's where the, once you hit that button, that's when the code is going to pop up. So you hit save and return later, and then that return code is going to pop up. Write that code down, and then if you have to go back in, you can click on the returning button and then enter in the survey code. We'll go through a sample, like I said. If you need to delete a submitted REDCap form, this is what we're asking you to do. You don't know, I think the previous slide said that you should reach out to STS. You can also enter it like this. If you entered in the patient ID and record ID correctly, if you want to remove it, use the same patient ID and record ID and just put the words remove after it. When we see that come through on the analytics side, we'll know to remove that case. Not necessary if you've already reached out to STS and asked us to remove the case for you, but something to do if you're not able to reach out to us. And let's go into a live demonstration of this. So oh, I guess that was silly. I should have just used the same slide. So let me go back up here. I'm just going to use the link for this one. So this is the neoadjuvant. You'll see this now, this returning button. If you've already completed part of the survey, you may continue where you left off. All you need is the return code given to you previously. Click the link below to enter the return code and continue the survey. So I don't have a return code yet. I'm going to go through and enter in. Oh, see, we even have checks in place there. Look at that.
Yeah.
I'm just going to make up a number.
Yeah, I would just do 4,000, 40,000.
Okay. I don't think we have a site. I don't know if we do
No,
or
we
not.
don't.
So patient ID is going to need to start with a V. And I'm going to use V12345. There are times where the patient ID and record ID will be the same, and I believe that happens quite often in IQVIA if you're a direct data entry user, and that's okay. The next record ID for that patient will be different, identifying a subsequent record ID. So today is the surgery date. And I got the patient started in there. Record ID is up here, patient ID is up here, so I can make sure I got those correct. And I'm just going to answer a couple of these questions. I don't know the PDL1 percentage. And all right, I'm going to stop here because I don't have the rest of this information. So I want to go ahead and save it and return later. This code pops up. You can easily just copy and paste it into your tracking log for this patient. Additionally, your survey responses were saved. Here's the code again. And then here's the survey link for returning. I don't know what that means, but oh, I guess it's the email. So I'm going to enter my my STS email here, or you can continue on to the survey now. If you continue on to the survey now, it's going to prompt you. It's going to open up that same one you just left. Oopsie. Let's see if it saved it. So it opened up this same one I just left by pasting in the return code. But I want to show you what this is going to look like in an email. So let me open my email on my other screen here. Hold on. Maybe. So it's going to come across, sorry for the other emails. It's going to come across as this administrator at sts.org, redcap at sts.org. It came to me, thank you for partially completing your survey. You may continue your progress on the survey by clicking the link below, and you'll need your return code. Click on that. And that's not what it's supposed to do, maybe because I'm already in the form. But when you click on that,
Yeah, I think that's why.
Probably because I'm already in the form. It'll return and you enter in the return code that you saved, and it'll open up the form. Okay, so we're gonna continue the survey and let's just say I'm going to finish this as quickly as possible. I have no idea if what I'm entering even makes sense, but this is just for
Just, yeah. Days.
whoopsie. We're just going to do no there. Okay, and I'm going to submit this. This form is complete. I'm going to submit it. It gives me the return code again, and then you can also download your survey PDF. So if you wanted to save all of your surveys, it'll download in PDF from right here, and it will look like this when it opens up. It gives you the patient information, time that it was submitted, what it's for, the time it was submitted, your site and patient information, and it gives you all your answers that you provided back if you wanted to keep a record of that. And I think that's all I had to show. Was there anything else I missed, Leanne?
No, Mary has a question and she raised her hand like right when you were going through stuff. So before we
Oh,
hopped off of the screen, I just wanted to see if she wanted to ask
yeah.
her a question. Hi, Mary. I think you're muted on
Oh,
your.
she got
Oh,
shy.
okay, she got shy. That's all right.
She got shy.
Okay.
Oh, hold on. Q&A. Do you
Um,
only get the email if you did a save and return, but not if you completed the entire input? So right. So it looks like we may have changed that. I think we're not sending out the survey. I thought we were sending out the survey, but I think something
yeah,
happened. You can download the form here. I'll have to check with our RedCap guru, Nikki. Because I don't see the link to send yourself an email. Let me try another one and see if we get it at the end. It may not have sent it to me because I had completed the form.
I can also answer Amanda's question while you're getting
Yeah,
that up.
sure.
So Amanda, she had asked if they're putting this in the database, do we also do this in RedCap? No. So if your vendor has put this these variables in your software, then no, you do not need to also enter it into RedCap. Not all the vendors were able to add these variables into their software. So only those that do not have these variables in their software have to put this information also in RedCap. Do you only get the email if you did save and return, but not if you completed?
Yeah,
then
it's not looking like we get the an additional email for that one.
yeah.
Oops. Okay. So if I want to enter in go back to one of the forms I already entered in, this is the screen where I had clicked on returning. I'm not sure if you saw that, but up here I clicked on returning. When I hover over it, this pops up and I just click on continue the survey. And then you can submit your code and it'll open up the form for you. And I guess it is just it looks like you could only get the email address, the email with the reminder when you're partially through the form. When you complete the form, it's the only time you can download the PDF with the answers. I hope that helped.
Yeah.
Okay. All right. I guess anything else?
I
Leanne, you
don't
wanted me to go
see
over?
any questions, but no, I think that's good, Carol. Thank you for doing that. I know
Oh, yeah.
you and Melinda had presented this to the ACSD side, and I had not had the chance to go in and work on these updates or play with
Yeah,
the
that's okay.
stuff.
I hope it's helpful. But if you have any questions, we're still here to help too. All right, I'm gonna stop sharing.
Okay, thank you.
Mhm.
All right. All right. Which screen am I sharing? Hold on. Let me try this again. All right, screen 2. I have too many screens open. All right, so I think you all should be able to see the fall 24 reporting updates
Yes, ma'am.
slide. Okay, perfect. All right, so thank you again, Carol, for going over that. I know hopefully those updates to RedCap really will help your, help everyone when you're putting in those forms, and the ability to go back and complete the form later, I think is a huge step in the right direction. So hopefully that you guys are pleased with that update. I just wanted to go over some fall 24 reporting updates that will be coming down the pike with the next harvest analysis. As you guys have heard, we will be implementing the revised risk models into the fall 24 analysis. So we have the revised risk models for the resection for primary lung cancer and esophagectomy. I'm not going to go into a lot of details about the revised risk models at this time during this webinar, but come back next month, and then we'll do a little bit more of a deep dive into, we'll just review risk model covariates, populations, things like that. So we'll save that for next month. So there are still some internal ongoing discussions regarding populations and things like that, and how everything will be implemented in fall 24. So more details on the risk model covariates, et cetera, population on the next call. But in the meantime, I just wanted to give you a heads up of reporting updates that are coming. So again, we're implementing the revised risk models. With the implementation of these revised risk models, there will be no more lobectomy for lung cancer risk model results. So again, the lobectomy for lung cancer risk model results will no longer be reported out. Again, it'll just be the resection for primary lung cancer and esophagectomy. The lobectomy legacy reports will remain within the report. So you still have that legacy report for lobectomy. The STS and NIS comparison outcomes reporting will utilize the resection population. In the past reporting, it had utilized lobectomy population. So that will be updating to the resection population. And the one thing that I wanted to touch on today is the removing the required fields criteria. So beginning with fall 24, that the required fields criteria will be going away. So just a little bit of a history of why we had these required fields in the first place. The required fields were implemented in the beginning of the general thoracic surgery database due to issues with data completeness. We had a really high data incompleteness rate. So the surgeon leadership had instituted this required fields requirement. So as you're aware, if a record has missing data for one or more of the required fields, the record is not accepted into analysis. So for example, where we're seeing several numerous risk model eligible records have been excluded from analysis due to missing a required field such as primary payer or TIN, or tracheal data was not answered, hiatal hernia data was not answered. So we were missing the opportunity to have numerous risk model eligible records being included due to missing one or more of these required fields. So we had a discussion. the GTSD task force reviewed the required fields and made the decision to remove this criteria beginning with the fall 24 harvest analysis. Removing this required fields will also align the GTSD database along with the other STS databases. ACSD does not have a required fields requirement, nor does CHSD. Also, please note that there are ongoing discussions regarding risk model variable missing data thresholds. Again, that's an ongoing discussion. We don't know if we'll have risk model variable percent missing thresholds, but as we learn more, as we talk, obviously we'll share things with you. I'll have more information about that on our next month's webinar. So what does this mean? No more required fields. If these are no longer required, this is the number one question. If these are no longer required, do I still need to collect this data? So yes, the answer is yes. So please don't, STS is no longer going to require these variables to be completed. That means I don't have to answer them. That's not true. Please remember, per your STS contract, you agree to collect complete and accurate data. So, and it's also very important to remember that some of these required fields are risk model variables. So you do want to ensure that your patients are being analyzed with the appropriate risk. In instances of where imputation happens for missing data, patients are assigned the lowest risk possible. So again, you want to make every effort to continue to collect these data so you ensure that your patients are being analyzed with the appropriate risk. What are next steps that are going to happen on the STS side of things? Next steps include obviously updating our current validation checks within the IQVIA platform. These, to include the critical errors and warnings. Right now, these required fields, I think the majority of them have critical errors. We'll be setting those to errors. So I'll be working with IQVIA this week and start working to get these validation checks updated within the IQVIA platform. Obviously, we will notify you once these updates occur. So I'll have more information again on the next webinar about when these updated validations will be implemented. Also, regarding the no more required fields and updated risk models, the analysis overview documentation obviously will be updated to reflect all of these upcoming reporting changes. So that will all be included and coming down the pike. I know there are some questions coming in before we move on to the AQO information. Let's see. So Nicole, can you repeat the information about the lobectomy? So we do have the legacy reports. The lobectomies is, there's a lobectomies report within the legacy reports. That report will remain, but the lobectomy for lung cancer risk model, the star rating, that report, that will no longer be reported out. I hope that helps to clear things up. Let's see. Fall 24 star ratings will involve all primary lung resections, not just lobectomy. Yes, so the resection population is currently laid out in the analysis overview. So the fall 24 ratings will include the resection population, resection for lung cancer, and then the esophagectomy. So those are the only 2 star ratings that will be reported out. That will no longer report out lobectomy for primary lung cancer. Will the required fields be retroactive? So the required fields will be, that criteria will be applied to the analysis window, the 3 years of data. Does that make sense? Hopefully that makes sense. If not, let me know. Okay. Will you be notifying surgeons or sending an official communication of the resection star rating will no longer be published? So it's the lobectomy for lung cancer will no longer be published. The resection will be published. So again, the lobectomy for primary lung cancer is the one going away, not the resection. This was reported at the annual meeting. And then also, but yes, there will be, we can send official communication regarding, the reporting changes, moving to the revised risk models. Again, Dr. Cedar did present this at the STS annual meeting. So many of the surgeons are likely aware, but again, we're happy to provide communication, Sheila, and we'll also include this in STS communications like database news, and then the surgeon related communications as well.
Hey, Leanna, it's Carol. Can I just jump in real quick?
Sure. Yeah.
Sure. I was just going to say there's also new papers, new manuscripts coming out that are going through the annals right now that'll be available before we start, should be published before we start.
Correct.
With
Yes.
this. Okay. Just so that their surgeons will also be notified through the annals as well.
Yep. Perfect. Thank you. AJ, I had not mentioned anything about the next audit. I did not. Emily, did you want to provide any information about the upcoming audit? I know CRS is working, audits moving forward. Did you have anything to share?
Hi, yeah, audit notifications will be going out for general thoracic at the end of May.
Oh, perfect. I'll make a note and include that in next month's webinar. Let them know that they were sent. All right, great. Thank you, Emily. Forgot to input that information. Is there a way we can receive a copy of that article? Are you talking about the annals, Sue? The risk model papers? Yeah. Carol, do we provide links to the through the annals, or you have to go through the annals to get that paper?
I think you'll have
Perhaps
to
your
go through the
surgeon.
annals. I think you'll have to go through the annals to get it. Oftentimes those types of papers are published with open access.
Mhm.
Otherwise, the hospital library should be able to pull them.
Okay, perfect. Thank you.
And the surgeons, if they're members, of
Mhm.
course, will have access to the annals.
Perfect. All right. You're welcome, Sue. All right. Next update that we have, let's see, we have AQO, as you're all aware. Before we hop into the AQO, I just had a quick poll. We're just trying to get some ideas about who all will be attending AQO this year. And I think Emily's launching the poll. So if you could please respond to the poll. So are you planning to attend AQO in 2024? Yes, in person. Yes, virtually only. Yes, undecided on which option, or no, not able to attend. So we appreciate you taking the time to let us know. This helps us tremendously with our planning, which is currently underway. All right. Looks like we have a good amount. I think we could go ahead and end it. So, oh, people are still answering. Just when I say that, they stop. All right, so thank you. So it looks like we have about, of those that participated, about 20% attending in person, 23 virtually, and about 23 undecided, and 34 not able to attend this year. So thank you very much for filling that out. We will share that with our meetings team. That is good. If you have any questions about AQO, please let us know. All right, speaking of AQO, again, as you all are aware, we'll be in Nashville, Tennessee this year, September 11th through the 13th. Registration is now open, so please encourage you to go ahead and get registered and take advantage of the early bird pricing. Just a reminder that our early bird discounts run through May the 16th, and then after May 16th, the standard rates will apply. And of course, here we have both our in-person pricing versus our virtual pricing. So again, just encourage you, for those that are coming, to take advantage of those early bird discounts. And with that, all that I have regarding AQO and fall 24 reporting update. So Nancy, I'll come back to questions. I'm going to go ahead and turn things over to Ruth really quickly so she can cover her updates, and then we'll get back to all of your questions.
Hi, everyone. Just a few educational updates this month. So as additional FAQs have come across to the core group regarding sequence 790, the SCS reconsidered the original intent of this sequence, which was to capture patients with a history of active substance abuse, meaning within 30 days of the index procedure. In order to better align with that original intent, revision was required for multiple FAQs. So in the May training manual, you'll see many strike-throughs and red letters in this sequence, but really trying to get back to capturing only patients who are actively within 30 days abusing alcohol, drugs, and nicotine. Let's go to the next slide. We received a bunch of questions on a specific esophagectomy endpoint, which I'm going to focus on in just a second. First, just a general reminder that the endpoints for analysis are listed in the analysis overview document, which is a magnificent data manager reference tool. If you have not reviewed the analysis overview summary, please go do so. Print a copy, it gets updated only with each harvest at most, generally. So this is one that it's safe to print and look at, unlike the training manual, which gets updated very frequently. So we're going to focus on the first endpoint, which is an anastomotic leak requiring medical treatment only. In version 5.21, it is sequence 3930. This is just a screenshot from the training manual of sequence 3930. As you can see, there are 3 different types with 3 different harvest codes for postoperative anastomotic leak type. The parent to this sequence, of course, is that your patient actually had a post-op anastomotic leak. And so this is the place where you're entering that type. If you want to go to the next slide. So the question then becomes, of these types, what falls into anastomotic leaks requiring medical treatment only? So I had our brilliant statistician, Harris, pictured here, review the harvest code, which is actually what I've screenshot right beneath his picture. So this, these if-then statements are what the actual code looks like when they do the harvest analysis. As you can see, if the anastomotic leak type in that blue box is coded as 1 or 2, then your patient is identified as having the post-op event of a medically treated anastomotic leak, which I know is a little bit counterintuitive, because if you read the type 1 and 2 definitions, one of them is interventional therapy, one of them is no change in therapy or dietary change, but this is how medical treatment has been defined for the purposes of post-op events. I'm gonna go to the next slide. So and I think that leaves a lot of people scratching their heads. Well, what about type 3 leaks? Those are the worst. When we want to capture those as an endpoint in the analysis, and those are captured. They're just captured under the unexpected return to the OR, because those anastomotic leaks are defined as requiring surgical intervention. So in the end, the goal of the STS is to capture all anastomotic leaks as a postoperative event, and they're just captured in 2 different places. One being maybe a little bit of a misnomer and calling medical, and the other one being surgical return to the OR. And that is the end of my updates for today.
All right, great. Thank you, Ruth. I know we've got a few questions coming in.
Sure.
I can take the first one. She was just asking, can you please review again the lobectomies and analysis? And I'm actually just going to pull up the IQVIA platform and screen share this for 1 second. Let me pull this. I just picked a participant. So just so I can give you an idea of changes that are coming. Just a moment. All right, so as I was saying earlier, for the upcoming fall 24 analysis, the biggest, we're implementing the revised risk models. So with those revised risk models, we will only, moving forward from fall 24, beginning with fall 24, we will only be providing star ratings for the lung resection composite and the esophagectomy. So the lobectomy composite rating and the lobectomy composite rating details, these buttons, these reports will no longer be available beginning with fall 24 harvest analytics. The STS NIS compare will no longer be lobectomy. This will be relabeled and analyzed with the resection population. So this will be the resection STS NIS compare. Again, these 2 buttons here, these 2 reports will be going away fall 24. The lung cancer staging procedures, there will be no changes, as this report currently includes the resection population. So there'll be no changes in terms of, the population being, in terms of that report. It'll include the risk model population. Lobectomy risk adjusted outcomes. This will be changed from lobectomy risk adjusted outcomes to reflect the resection population. So this report will, moving forward, will be called resection risk adjusted outcomes. And then obviously the lung cancer resection composite rating details and the lung composite rating and the composite rating details. These reports will remain. When I was referring to legacy reports, this was what I was referring to, the lobectomy report here. This report will remain. So this report, there will be no changes to this report. This report will remain. This is the lobectomy report that will be staying for fall 24 forward. Hope that helps clarify just a little. Hopefully that helped. So yes, we'll be sending an official STS email with the change in the reporting. So will lobectomies be included in the lung cancer resections report? Yes. So actually, if you pull up the analysis overview right now, you can see that lobectomies are included in the resection. Lobectomy. Where's the resection? Resection. So, and here you have all of the procedures that that are included in the resection, currently included in the resection. You have your pneumonectomies, your lobes, your bilobectomies, segmentectomies. So they are included in the resection population. So why is lobectomy going away? So the GTSD surgeon leadership decided to revise the resection and the esophagectomy risk models. I don't know, Carol, do you have any other? I know they need to move forward with the resection because it includes both of, a more wider population.
I think you're getting it, Leanna. It's the bigger populations, and it gives a better assessment of sites because we have a larger N to assess quality at sites. So it still includes the lobectomies. It's just a larger population by including other parts of pulmonary resections now.
Just making sure I wasn't missing anything.
You weren't missing anything. You were spot on.
Spot on.
Yeah.
All right. Ruth, it looks like we have a couple of questions that may be clinical, clinical, but I don't know if you can answer these or if you want to try.
Katie, I don't know the answer to Laura's question offhand. I don't know, Katie, if you do. I'm looking in the training manual quickly, but
I don't have mine pulled up either. I can look, but if you're already doing that.
So while you guys are looking into that, I can answer Amanda's question. So Amanda asked for the entry of REDCap into the database. Is there a way to add or make it possible to place NA or none for therapy received? Excuse me, these fields never go away and stay missing or unanswered on all patients otherwise. So Amanda, we can take that back. We can only update the REDCap we have a fixed schedule of when we can update the REDCap. So we're likely looking at doing it maybe once every 6 months. But I will add this to the list of updates and bring this to Dr. Cedar as an ask for an update to those fields. NA or none for therapy received. So I'm just making a note. So thank you for that feedback. All right. You're welcome. Thank you.
I can answer Stephanie's question. How do I code 2 segments? You just enter it once. I think that clarification is published in the training manual.
Okay. So, great. All right, so you answered Laura's. I'm sorry, I was reading the question from Elizabeth.
Oh, sorry.
No, you're fine.
I don't have an answer to Laura's question. I can, Laura, we can look it up and get back to you unless Katie, you found it.
Yeah, no, I'm looking. I don't see anything that's specific to the 2 that she has here do just say via thoracotomy. And we do have some codes that are that way. And if there's no other, if there's not a minimally invasive option, then most of the time we just have to use the thoracotomy code if that's all we have. But yeah, I don't know if Ruth, if you want to get back to her on that specifically, but from what I can see, there isn't one based off those codes.
Okay, I didn't see one either, so, I would for now go ahead and use the thoracotomy codes, Laura, and then I'll take it to the core group just to run it by Dr. Cedar and, the other physicians there, but that's, as Katie said, historically what we've done. So I've copied and pasted your question into the May core group list.
Awesome. Perfect. Thank you. And then Dion had a question.
I can answer that one. You
Okay.
can use you can use both. And I'm assuming if the cancer was in the lobectomy, that's what's going to be your primary. They have the same weight, they're weighted the same. So you won't get an error if you record both in the procedures question. And then you just want to list your primary procedure in the primary procedure question, which I assume would be the lobectomy.
Okay.
But it's okay to use both of them.
Cool. Thanks, Katie. So Elizabeth, you didn't hear the answer. Sorry about that to my, to your question. So yes, there will be notifications sent to surgeons about, fall 24 reporting updates. We'll also obviously talk about it. If your surgeon's on task force, it'll be, it's been discussed there. And also if your surgeon was at, the STS annual meeting, Dr. Cedar did present this at STS annual meeting. So your surgeon may be familiar with the updates through there, but also, we know not everyone can attend every meeting. So therefore, we'll send out a communication to participants about, the reporting changes and the revised risk models, and then the lobectomy star rating no longer being utilized. Will AQO provide nursing CE credits?
We plan to provide nursing CE credits and perfusionist CEU credits through a core Excel again this year for both in-person and virtual attendees.
Awesome. Thank you, Emily. All right. While we're waiting for any additional questions, again, next monthly webinars, our next one is June 12th. And again, as I discussed earlier, we'll go a little bit more in depth about the revised risk models and the populations, endpoints, covariates that being utilized. We'll again, like I said, go a little bit more in depth and review all of that on our next monthly webinar. And then after June, our following webinar is scheduled for July 10th. And as always, if you have any questions regarding reporting, regarding your most recent report, regarding the IQVIA platform, uploading data, please reach out to us at stsdb_helpdesk@sts.org. If you have any questions, if you're not sure who to send your question to, just please feel free to reach out to me directly. You can always reach me at ljones@sts.org. And then if you have questions regarding contracts or payments, reach out to us at stsdb@sts.org. All right. I'm not seeing any additional questions come in. Can you put up the webinar schedule again? Sure. Absolutely. There you go, Nicole. So again, June 12th at 2:30 Eastern, 1:30 Central, and then July 10th at 2:30 Eastern, 1:30 Central. All right. Well, I guess since we don't have any additional questions, we'll go ahead and end for today's call. So again, thanks everyone for joining today. I appreciate it. Again, if you have any questions, just please feel free to reach out to me directly. If not, we'll see you all next time on our June webinar. Thanks everybody for joining. Thanks, Katie, Ruth, Emily. Thanks everyone for being on today. I appreciate it.